you, Charlie. Thank you, everybody, for coming. It's nice to be here. It's been many years since I've been in a real library. Now, these days, we usually download the kinds of things we need for our research work. Even in the hospital, we don't need to go to the library that much. But Charlie gave me a great tour of the place, and really very nice place. So welcome. Thank you for being here. So in our group at Mass General Hospital, we study depression of different types, and actually seasonal depression is only a small part of what we do, and maybe if there's time at the end I can tell you more about some of the other activities we do. But today I'm going to focus on what we call seasonal affective disorder, which is the official name for what we call seasonal depression. This is my list of disclosures, which academic doctors are asked to show. There's been various companies that have supported my research in some speaking engagements, including this one, which I've listed at the bottom. So to start with, this is a picture of me about 10 years ago. The Boston Globe interviewed me on seasonal depression, and they decided to take some pictures outside. So we went downstairs, and as you see, there had been a recent snowfall, and they sat me down on the bench, and the photographer kept taking pictures and pictures and pictures, and I kept getting colder and colder and colder, and by the end I looked positively miserable, and I think this helped convey, the horrors of winter in the Massachusetts area. So I'm going to talk about various things. I'm going to talk about the epidemiology of seasonal depression, how common it is, and who it affects, and then how do we go about diagnosing it in the clinical setting. And I'll talk about some of the underlying physiologic mechanisms that may be involved in causing seasonal depression. And then I'm going to talk about different treatment approaches, including light therapy, which is one of the mainstays of treatment of seasonal depression. And then we'll do a demonstration of the new lamp that the library has just obtained. So let me talk about depression in general. So depression has a prevalence of about 10 to 20% worldwide, which means that about 10 to 20% of all individuals may get depression at some point during their lifetime. And among individuals with depression, about 10 to 20% of those will have a seasonal pattern. And I'll talk a little bit more about what we mean by seasonal pattern in a moment. Not surprisingly, the prevalence of seasonal depression is associated with latitude. So the farther north you go, the more likely you are to get seasonal depression. So let's compare some statistics. The rates are about 9.7% in New Hampshire, our neighboring state, but only about 1.4% in Florida. So basically we need to get south more often. Depression generally affects women more often than men. The ratio based on different studies may be in the range of about 2 to 1, although in some studies it can be as much as 9 to 1. So most of the patients that we see in our clinic are women, though we do see many men as well. So now let's talk about seasonal affective disorder. So seasonal affective disorder is a subtype of major depressive disorder. Let me point out also there are other mood disorders like bipolar disorder, which is also called manic depression, which can also have a seasonal pattern. So typically mood episodes occur and then resolve or remit at a specific time of the year. So typically, people with seasonal depression will get depressed in the early fall or early winter, and then they'll be depressed throughout the winter, and then in the spring, they may remit to their normal state. In cases of bipolar illness, those individuals may be prone to having manic episodes during the spring or during the summer. This is the most common pattern for seasonal depression, but sometimes it can go the other way. There are some people who actually get depressed during the spring and summer and may feel actually better during the fall and winter. It does happen, though it's less common. When we're diagnosing seasonal depression, usually a person may come in presenting with depression, and we'll ask them about whether there's a pattern. If they've had multiple episodes, we ask them, do they tend to start in the fall and then clear up in the spring? So for the diagnostic criteria, we like to see at least 2 consecutive episodes in the fall, and then clearing up in the spring. Now, people with seasonal depression may also have depression at other times of the year and without the pattern, but in general, the seasonal episodes will be more common over the course of an individual's lifetime. Depression tends to be a recurrent illness, which means that people may have many episodes during the course of their life. The more we understand it, the more we conceptualize depression as an illness that's more chronic and requires controlling rather than obtaining a full cure, which is unfortunate, but that's what our research has shown over the years. Now let me talk about the formal diagnostic criteria of depression. And these are the way they're laid out in the Diagnostic and Statistical Manual, or DSM, of the American Psychiatric Association. It's currently in its 5th edition, or we call it the DSM-5. So to meet criteria for major depressive disorder, the individual must have a depressed mood most of the day, nearly every day, over at least a period of a couple of weeks. And or a loss of interest or pleasure in activity. So the person may feel less motivated to do things in general, or they may be doing the things they normally do, but they may find that they don't enjoy their usual activities as much. So you need to have at least one of those 2 symptoms for starters. And then you need a total of 5, including the others that are listed below. So for example, sleep disturbances, either not sleeping well or sleeping too much. I mentioned decrease in interest, guilty feelings, typically ranging from self-criticism, putting oneself down, to dwelling on past mistakes, and sometimes even thinking that the depression is some kind of punishment for a bad thing that the person did. Energy also tends to be decreased. Fatigue is very common in all types of depression. There's problems with concentration. People usually will have trouble reading or doing other tasks that require sustained attention. They may also have memory difficulties, easily forgetting things like where they place their car keys or forgetting appointments. Appetite can also be disturbed. Like sleep, it can go in either direction. Some people tend to lose appetite. They may stop eating or skip meals. Often they'll lose a lot of weight. And then there's other people who may actually be eating more than usual. And that's actually one of the things we see in seasonal depression, which I'll talk about more. And then there's what we call psychomotor changes. So a person may experience themselves as feeling slowed down, feeling like their thoughts are going more slowly than usual inside their head, or feeling like they're moving more slowly than normal. And then there's the opposite, psychomotor agitation, where a person may feel very fidgety or restless. They may have trouble sitting still. They may notice themselves tapping their foot a lot, needing to get up and pace, and so forth. And finally, suicidal ideation. So what do we mean by that? So suicidal thoughts are common in depressive disorders. It can be a person feeling that life is not worth living or that they'd be better off dead. It might be wishing they would actually die, for example, wishing they'd go to bed and not wake up the next morning. And at the extreme, it can actually be thinking about hurting or killing yourself, either thinking about suicide in general, or actually getting to a point where you're imagining how you might do it, like hanging yourselves or buying a gun or overdosing on medications. So those are the kinds of suicidal thoughts that we might see with depression. So again, you need to have a total of those 5 symptoms to meet formal diagnostic criteria for depression. And these are the kinds of things that a psychiatrist might ask about if you go in to see one with a chief complaint of depression. Now let's talk a little bit about mechanisms of depression and seasonal depression in particular. There's a chemical called serotonin, or 5-hydroxytryptamine, which is diagrammed below. And this is a chemical that we all manufacture, and it's particularly important in the brain. It's involved in various interactions that occur between different brain cells. We know that a deficiency of serotonin can be potentially a cause of depression. We also know that during the winter months, serotonin turnover or serotonin metabolism can also be decreased. On the other hand, when people are exposed to light, serotonin synthesis actually increases. So in general, depression is thought to be associated with decreased function of serotonin. Many of the antidepressants out there, like Prozac, Paxil, which you may have heard of, those usually function by increasing the amount of serotonin that's available inside the brain. Regarding seasonal depression, another potential chemical involved is the hormone melatonin, which you see at the bottom right of the slide. So melatonin is a hormone that we manufacture in the brain in a portion called the pineal gland. You can see the diagram on the top right. And melatonin is very important. Many of you may have heard of it as a natural supplement that people take to help them to sleep. We know that during the winter, obviously there's less daylight and less intense, as well as shorter in duration. Consequently, fewer photons of light hit the retina of the eye, as diagrammed in the picture on the top left. We know that there's a relationship between light and melatonin release. So when there's less light hitting the retina, more melatonin might be released. And during the winter months, we tend to release more melatonin in general, but people with seasonal depression are way more likely to have higher levels of melatonin compared to healthy control individuals without seasonal depression. We also see this in all kinds of mammals. In fact, it's believed that melatonin is one of the major drivers of the process of hibernation, for example, when bears sleep through the winter. And we think that this might be also a contributor to seasonal depression. In this picture, I'm showing what happens to the sleep-wake cycle in seasonal depression. So what happens is the cycle is delayed. So as you see in this graph, in the middle curve, it's essentially the normal phase. So from about 10 o'clock at night to 11 in the morning is when melatonin levels are at their highest. With seasonal depression, as you see toward the right, the curve is shifted to the right so that you're less tired at your regular time to go to bed, and you tend to be more tired in the morning and during the day. And this cycle can get very distressed to a lot of people. In addition to melatonin, some of the cortisol-related hormones might be involved as well, and there's also changes in body temperature that may occur. How all of this contributes to developing depression is not clear, but a lot of research is being done to try to understand this mechanism. And then there's genetic factors. Now, we know that depression tends to run in families. If you have a parent or a sibling with depression, this increases your chances of developing depression at some point in your life. And research has shown that there are many genes that may be potentially associated with depression, although they haven't found one single gene responsible for it. In particular, genes that are involved in the transporter of serotonin. I mentioned the importance of serotonin. So genes that are associated with the transporter may have a link to seasonal depression. Another important neurochemical is dopamine, and these receptors for dopamine might be associated with binge eating behavior that we often see in seasonal depression. And there's other genes that may also affect the circadian rhythm, the body clock through still not characterized mechanisms. In addition to physiological issues in the individual's body, we also have to consider psychological issues. And this dual vulnerability model proposed by Jung addresses this matter. So the idea here is that there are certain people who may have a physiologic predisposition or vulnerability to developing symptoms of atypical depression during the winter. In particular, we see fatigue or tiredness, hypersomnia or increased need for sleep, increased appetite, and in particular cravings for carbohydrates. People with seasonal depression will often like to snack on chocolates, potato chips, and things like that. At the same time, the psychological vulnerability can result in mood disturbances and cognitive symptoms in terms of how the individual interprets these physiological symptoms. So perhaps the person gets upset because they're eating too much, and that may make them more depressed, or they may be upset with themselves because they're spending a lot of time sleeping and not getting out enough. They get into sort of a vicious cycle that they can't easily get themselves out of. Which leads us to cognitive behavioral models. Now, there are forms of psychotherapy called cognitive behavioral therapy, or CBT, that aim at helping the individual to train themselves out of negative or dysfunctional attitudes, or things we call negative automatic thoughts. For example, let's say you're at work and your boss gives you some constructive criticism. A person with depression might think, oh, my boss hates me, my boss is going to fire me. And so they start ruminating and having those thoughts over and over. And that can contribute to getting them more depressed. And we call this, in ancient parlance, it was called neuroticism. This has been seen particularly in women with seasonal depression compared to women who were not depressed. I talked about rumination, so what this means is that people will start to focus intensely on what may be causing their depression or what may happen as a result. And people who tend to get into this pattern of thinking in the fall are more likely to have more severe depression symptoms during the winter months. So these are the theories that seem to explain depression in general and seasonal depression in particular. We have yet a lot more to learn about it, but I think this gives you an overview of what are some of the mechanisms that have been proposed. So now I'm going to talk about different approaches to treatment of seasonal depression. There's quite a variety, as you will see. So let's start with light therapy, which is considered generally the treatment of choice. It's certainly the best studied treatment. It has the most scientific studies that have been done to try to understand its efficacy. So light therapy consists of having a box, as you might see over there. That one's not really a box. It looks quite sleek, actually. They've advanced over the years. The box contains fluorescent lamps, and they generate a very strong light, typically in the range of 10,000 lux of the full spectrum or cool white fluorescent light, sometimes behind an ultraviolet shield. Typically, the recommended exposure to a lamp like this is for 30 minutes to 2 hours, usually a couple of times a day, and for at least a period of 2 to 4 weeks consistently before you actually see results. Lamps don't all have to be 10,000 lux. There are some that have lower intensities. For example, 2,500 lux. The one that you're going to see here has two settings, one for 10,000 and one for 5,000. Those are effective as well, but the lower strength ones may require longer sessions or treatment for longer periods of time in order to get the same effect. As I mentioned, many studies have been done with light therapy for seasonal depression. One of the problems is that most of these studies tend to have small samples. In other words, to do a very good, rigorous clinical trial of any treatment, you tend to need large numbers of people. Probably for depression, we like to have somewhere between 200 and 300 people in a study. Some of these studies of seasonal depression may have 20 or 30, 40, 50. So we consider them good pilot studies as far as giving us an idea of efficacy, but we can't really know with certainty until we do larger studies. There are statistical procedures for putting together a bunch of small studies into an artificially large one. And what these pooled analyses have shown is that about 53% of people who try the light therapy for seasonal depression will have a full remission. Remission meaning that the symptoms will resolve more or less completely. So this is encouraging. However, for many people, light therapy may not be enough. It may get them some improvement, but not necessarily get them to the point where they feel 100% normal. In those cases, sometimes a good strategy can be to combine light therapy with different kinds of antidepressant medications, and I'll talk a little bit about what we know in that area. Before we get into that, I want to talk a little bit about the side effects of the lamp. Some people may experience headaches as a result, or eye strain. This is often the result of putting the lamp too close to you, or maybe having too long a session. And there are some people who are more sensitive to the light than others. When we do the demonstration, if some of you want to try it, you'll be able to tell the difference between 5,000 and 10,000. Some people can experience agitation or irritation after some exposure, and even in some cases nausea has been reported. These are generally benign symptoms, and they'll go away as soon as you stop using the lamp. What do we do to prevent or stop these side effects? Oftentimes having shorter sessions with the lamp, sometimes as little as 20 minutes may be fine. Have the light box a little farther from you, don't put it right next to you. Take breaks between sessions. I usually recommend one session in the morning and one session in the evening, and that spreads them out nicely. And sometimes using the light therapy at a different time of day may be helpful. What I usually tell people is that sometimes you may need to experiment with when you do the treatments, how often and for how long, until you find the routine that works for you. Nothing really is written in stone. There are some more serious questions that I have to mention. People with certain types of retinal disease should be especially careful about using light therapy. You should definitely talk with your eye doctor about it in advance to make sure that it's safe. There are certain medical conditions, for example, lupus, an autoimmune illness, which you may be familiar with, and certain medications that can increase sensitivity to light. So again, individuals with these conditions need to be careful also about using the therapy lamp. I mentioned in individuals who have bipolar disorder who may switch from depression to mania, sometimes light therapy can trigger mania. In other words, the person who starts using it to treat depression may suddenly switch over into a manic episode. This can occur, by the way, with any antidepressant treatment. So we usually tell people that if they have bipolar disorder or suspect they may have it, they should probably be assessed by a psychiatrist to make a firm diagnosis, and also to come up with an effective treatment strategy to manage the depressive portion of the illness without triggering mania. This is very important because manic episodes can have very serious consequences for individuals. Now, light therapy can be used for other things besides mood disorders. First of all, there are certain types of depression and mood disorders that don't occur seasonally, so it can be used for pretty much any kind of depressive disorder. There are some people, for example, who are very sensitive to side effects from antidepressants and may prefer to use something that doesn't potentially cause the same side effects. So in many cases, light therapy can be tried. In many cases of people with more chronic depression who are doing okay on the standard antidepressant, many of them will find that during the winter months, the depression may get worse. Now, one strategy, of course, is to increase the dose of the antidepressant. That we often do that, but sometimes that can increase the risk of side effects. Sometimes adding light therapy during the winter months can be a good way to keep the depression in check during the winter. So the individual will continue their medication, but use the therapy lamp as well during the winter. What else? Jet lag. So this is something that we often experience if we travel across time zones. If you go from here to California or from here to Europe, you might find that sleeping gets difficult for the first few days. You may feel chronically fatigued. And sometimes light therapy can be effective, a good way to combat the effects of jet lag. In some sleep disorders, there are some people who have chronic problems sleeping. The therapy can help probably by re-regulating their melatonin levels and release. Now, sometimes people work in fields where from time to time they may have to work at night. Certain shift workers, nurses, security guards, and physicians. Sometimes using a therapy lamp could be a good way to help adjust more rapidly to that schedule. And finally, in dementia, one of the things that happens in people with dementia is that, particularly when it gets dark out, there's less stimulation, and so they can get confused. We call this process sundowning. And sometimes a little exposure to the therapy lamp might be beneficial. It might help the individual to feel a little more calm and a little more aware of their surroundings. So these are all other indications for the therapy lamp that can be used. They're not nearly as well studied as for seasonal depression, but they are certainly viable applications. So let's talk a little bit about strategies. If you do decide to use a therapy lamp, it's always a good idea to discuss the matter with a doctor, ideally a psychiatrist or a psychiatric nurse practitioner, but a lot of primary care practitioners also know about seasonal depression, and they may be able to advise as far as what might be the optimal way of using the therapy lamp based on what your own rhythms are in your particular lifestyle. There's some evidence that if you have your first treatment in the morning, this may have the best effect as opposed to evening exposure. So if you're only going to have one treatment a day, it seems that doing it in the morning is probably the best. But ideally, 2 sessions a day is what most of the research studies recommend. So usually a session perhaps when you first get up in the morning, and another session sometime in the evening. Let me point out that there are smaller transportable lamps that are available. For example, if you travel a lot and would like to have the lamp with you, there are lamps you can get for that particular use. They're not quite as bulky as the one you have here, so it'll be easier to fit in your luggage. All right. So what's the best time frame for using the lamp? So typically, best to begin early. In the early fall, when it starts to get cloudier and the days start getting shorter, that's probably the best time to start, even before you actually start feeling more depressed. And then keep using it until the spring, and at that point, when the spring comes around, the outdoor light can help to sustain your mood and your energy. A lot of people are also prone to having mild recurrences of their depression if they happen to have a streak of bad days during an otherwise good season. For example, there might be a summer where for whatever reason you get 6 consecutive days of clouds and rain. People may also use the lamp during those circumstances if they're particularly sensitive to a sudden change in the environment. The key is, and this is true about any treatment for depression, is that you should find a schedule that works for you, something that's compatible with your situation and lifestyle, and stick with it. I mean, the key is consistency. You really have to do this every day in order to get the benefit and to sustain it during the long winter months. So how do we use the lamp optimally? So in general, the 2 most popular settings are either at your work desk, where you may spend a lot of time, or next to your easy chair where you might sit to watch TV. The reason being that you can turn on the light while you're doing something else. You might be reading a book, you might be working at your computer, you might be writing, you might be watching TV. So basically this represents an efficient use of the lamp, because a lot of people think, oh, I've got to do this for 30 minutes twice a day, and they think that they just have to sit in front of the lamp and do nothing during that time. No, you work it into your schedule so that you're doing something that you would be doing anyway, working, watching TV, etc. And so it doesn't become cumbersome, it just becomes part of your routine. You could keep one in your office if you want and have it at your desk there, or at home. Another important thing is let the light hit your eyes indirectly. As you see the woman up there, see the light is at an angle, so it's not pointing directly at her. This is because the direct light can actually be irritating or harmful to the eyes, so having it at an angle is probably the best way to use it. And we'll do the demonstration later, and you'll see it for real. Now, there's also another line of research into ultraviolet light. Basically, ultraviolet light irradiation can be applied to the skin or the eyes. And there's about 7 studies, of which 6 suggest that there is benefit and improvement in mood. But these studies, as I mentioned, tend to have small samples and vary a lot in terms of their design. That's what we call heterogeneity of studies. So we need to do more research on this, and I consider the results of these studies very preliminary. I also tell people, don't try to use a tanning booth to treat your seasonal depression. It probably won't work, and it could expose you to more UV radiation than you really want. So that's a little caveat there. Okay, now what about medications? Seasonal depression is a little more difficult to study in the research setting because we have a narrower window to recruit people who might participate. You only get the fall and winter, whereas with most forms of major depression, we can recruit people all year round. So consequently, there are fewer studies in seasonal depression. The most common medication used is the selective serotonin reuptake inhibitors, or SSRIs, either by themselves or in combination with light therapy. So certain ones like fluoxetine, which is the generic name for Prozac, a small study with 11 people showed about a 61% remission rate. A study comparing sertraline or Zoloft against placebo suggested that the sertraline was better than placebo. Another study combined light therapy with citalopram, which is also called Celexa, and compared it against light therapy plus placebo. So the question is, does citalopram add to the benefit from the therapy light? And in fact, the combination of the light therapy plus the antidepressant worked quite well in the long term. Usually by a period of 34 weeks, the individuals who received the combination were doing better than the ones who just received the light therapy without the antidepressant. There's other medications that have been tried in seasonal depression. Moclobemide, which is a monoamine oxidase inhibitor antidepressant, was shown to be effective in a small sample of 8 people. Modafinil, which is a stimulant medication usually prescribed for narcolepsy, which is that condition where people suddenly fall asleep for no reason at all. It showed about a 67% response rate, so about 2/3 of the patients had a significant improvement, whereas the reduction of symptoms was in the range of about 50%. In most depression studies, if the severity of depression based on symptoms reduces by 50%, we consider that a response. That's the term, the technical term for response. Remission means that most of the symptoms are gone, and the individual has really very little left in terms of depression symptoms. In most studies for depression treatments, they'll report response rates and remission rates, and now you know what these mean. And finally, propranolol, which is a beta blocker drug, which is used primarily to manage high blood pressure. It actually had some benefits in people with seasonal depression. About 73% of people got better after 2 weeks, which was a very encouraging finding. It's thought that the propranolol may somehow suppress melatonin, and that may be how it works. So these are some of the medications that have been used to treat seasonal depression. And then there's cognitive behavioral therapy. So when I mention psychotherapy, probably most people get a mental image of the individual lying down on the couch and talking to the analyst, and the analyst sits there writing and saying very little. Cognitive behavioral therapy is a different type of therapy. Here the therapist actually has a more active role, and the therapy occurs more as a dialogue. Cognitive behavioral therapy has been applied in mood disorders, anxiety disorders, and other conditions. And many different cognitive therapists have adapted the strategies to deal with specific conditions, including seasonal depression. So some studies have used 90-minute sessions twice weekly for about 6 weeks, and have shown them to be beneficial. The goal really is to counteract the hibernation effect of seasonal depression. So this involves encouraging the individual to get more activity in the winter, get out of bed, get out, walk, be more active. Likewise, it also works to eliminate some of the negative cognitions or negative ideas that people may have about the winter months. So it helps them to develop a more positive view of the winter, and that can help with the seasonal depression. There was a study that actually compared cognitive behavioral therapy alone against light therapy alone and against the combination of CBT plus light therapy. It turns out all of them were quite effective. The combination of the two didn't seem to work any better than either one by itself. So this was kind of unexpected, but in any case, the point is that either CBT or light therapy can be effective for treating seasonal depression. And then there's exercise. So getting a person with depression to exercise regularly is difficult to do. I know from trying to encourage some of my own patients to exercise. However, research has shown that aerobic exercise, often something like a stationary bike a couple of times a day for 25 minutes in a week, can actually produce good benefits, and in some cases even as good as light therapy. Other studies have shown that if the exercise is done under a bright light, usually in the range of 2,500 to 4,000 lux, this is actually more effective than either doing no exercise at all or exercising under normal light. And this is particularly true for the atypical symptoms, which refer to the increased appetite, increased need for sleep, among others. So I think the take-home point here is that doing exercise is very helpful, and in particular, if you do the exercise outdoors, that might be even better than doing it, say, in a gym. So something to consider. Finally, I'm going to talk a little bit about a study that we did in the depression program about 10 years or so ago. I'm actually showing this Calvin and Hobbes strip. As you know, Calvin's favorite cereal is chocolate frosted sugar bombs, and you see, for him, you need to add a little more sugar, but for Hobbes, that's more than enough. And the reason I use this cartoon is because we actually used a carbohydrate-rich mixture in order to treat seasonal depression. I'll tell you about that. So this was a product called PMS Escape. As its name implied, it was originally marketed for treating premenstrual syndrome symptoms. The team at MIT that had developed this product, it was led by Dr. Richard Wortman and his wife Judith Wortman. They were interested in studying it in seasonal depression. So this consists of a carbohydrate mix that has 40 grams of starch, including maltodextrin, dextrose, and dextrin. And these are all carbohydrates of different lengths. Some are broken down more quickly, some are broken down more slowly. Another thing they do is that they actually promote serotonin synthesis in the brain, which made us think that perhaps this could have an antidepressant effect. By using different lengths of carbohydrates, this can help keep your blood sugar more stable, controlling carbohydrate cravings so that you won't snack as much, and this could also help stabilize weight. So that was the theory that was proposed when we designed the study. So what we did, we needed a placebo intervention. So what we did was we came up with a carbohydrate and protein mix, which consisted of the same carbohydrate mixture used in the active beverage, but a lower amount. And instead, in addition, we added 15 grams of the casein milk protein. What this does is it prevents the tryptophan uptake in the brain, and so it lessens serotonin synthesis. Serotonin needs tryptophan in order to be synthesized. So we thought that the protein would basically block the effect of the carbohydrate drink, and so we'd have one active intervention and one placebo intervention. So we did two studies. In the first study, we recruited 18 individuals of about mean age 43 with seasonal depression, and they were given either the carbohydrate drink twice daily or placebo for 12 days. And then after a 2-day washout period, which means that they complete the treatment, and then for 2 days they receive nothing, then they're switched over to the other treatment for 12 days to see whether it makes any difference. What we found overall is that about 50% of the people in both groups got well. So essentially, it didn't matter whether you had the active drink or the placebo. Now, with regard to remission rates, meaning an almost full resolution of the depression, the carbohydrate drink did a little better than the placebo. So 50% of people experienced full remission with carbohydrate drink mix versus 38% on the placebo. But the differences were not statistically significant. What we mean by that is when we do a comparison of two treatments, if we find a difference, we want to make sure that the difference may not be due to chance alone. This is why we generally need large samples. If you find a difference in 100 people, you can believe it more than if you find differences in groups of 10 people. Statistical significance means that there's less than a 5% chance that your findings were due to random luck. So in this case, because the sample was small, we couldn't get a statistically significant result. We did another study in which we treated 32 people for a longer period of time, 21 days, of the same carbohydrate drink mix or the placebo. As you see here, we found no difference at all. So the carbohydrate drink group produced response rates of about 71%. The placebo actually did a little better, although this is not significant. Remission or full resolution, about 71% of people in each group got well. Other things we looked at, whether this had any effect on weight. There wasn't a very significant difference between treatment groups, but then again, it wasn't a very long treatment period, so we wouldn't necessarily expect a difference in weight change. We also found the drink mix was generally well tolerated, didn't have any unpleasant side effects, and people stayed with it. They took it for the duration of the studies. So to conclude about this particular study, basically we found that the active carbohydrate drink mix plus the placebo were both effective. This is a problem in many studies of depression, that placebo response rates tend to be high. It's the power of suggestion. So in general, if you pool most studies of depression together, about 30% or more of people who receive a placebo will actually get well with, if they have depression. So this complicates research because it means we need very large samples of people to really get convincing results. So if we want to learn more about this particular product, we'd have to do larger studies. Let me make a few concluding remarks. So seasonal depression is pretty common. As I mentioned, about 10 to 20% of people with depression will exhibit a seasonal pattern. There are many treatments available, so this is a treatable condition. Unfortunately, we don't have a lot of good quality research to identify the optimal treatments from the standpoint of whether one is better than another and what might be the optimal doses or dosing schedules. So we need to do a lot more research in this area. So to close, I'm going to give some recommendations. And the first one, which I think is very important, if you think you might be depressed for any reason and think you need help, your best bet is to first talk to your primary care doctor or see a psychiatrist or other mental health professional, a psychologist, a psychiatric nurse practitioner, someone who's got the expertise to make the diagnosis correctly and then make a recommendation about treatment. If you have seasonal depression and you have a particularly severe form, light therapy may not be enough. You may need a combination of treatments such as an antidepressant plus the light therapy. Another consideration is vitamin D. There's been increasing evidence that vitamin D deficiency could be associated with depression. And certainly in this part of the country, because we don't get a lot of sun exposure and vitamin D synthesis in humans depends on exposure to the sun, many of us may be running around with mild or moderate deficiencies in vitamin D. So it's often a good idea to check if you have seasonal depression. Whether you get treatment for yourself or not, there are other things you can do in general just to combat the winter blues. I tell people Try to avoid the desire to hibernate and stay in bed and stay indoors all the time. Go easy on the sweets as much as possible. Try to establish a healthy sleep pattern. We call this good sleep hygiene, meaning try to go to bed at the same time each night and get up at the same time each morning. If you can police yourself to do that, that can have a tremendous benefit. And finally, try to be physically active. Now, we talk a lot about exercise and jogging and bike riding, etc. But even moderate walking, just walking for a half hour a couple of times a day, can have beneficial effects on mood. And so you don't have to think that exercise involves something really rigorous. It's the sort of thing that anyone can do. Any kind of physical activity outdoors is a good thing to do. So finally, I want to thank you for your time, and I'm ending with a picture of the bright sun. Hopefully, we'll get some of that, in the next month or two. So thank you all very much.